Now, esophagus, what are the probable questions that might come if anything related to the esophagus? Write short notes on esophagus: origin, parts, relation, clinical anatomy. Enumerate sites of normal constriction of esophagus and their levels. Mucomuscular tube connecting pharynx with stomach. Has 3 parts: cervical, thoracic and abdominal. Now, enumerate of sites of normal constriction of esophagus and their levels. When a normal constriction of the esophagus, but if there is any growth or malignancy or some pathological changes in the esophagus, then there might be difficulty in swallowing, and that gives a there might be a constriction. That's why it's writing the normal levels of constriction of the esophagus and their levels. It is a mucomuscular tube connecting pharynx with the stomach. Now, you have seen the oral cavity. I have showed you the pharynx and the trachea in the specimen is there. Now that continues. Now the pharynx, and it has pharynx, connects pharynx with the stomach. Has 3 parts: cervical, thoracic and abdominal. Now the cervical part, thoracic part and abdominal part. Okay? Now measurement 10 inches. Now MCQ, this is the MCQ question might come up. Length 25 centimeters, width 2 centimeters. Lumen normally closed and opens only during passage of food. Now the lumen now usually when the food passes, it is open, but normally it is collapsed, it's closed. Now esophagus begins as a continuation of the pharynx and lower border of cricoid cartilage. When you dissect the thorax, the larynx, the cricoid cartilage is there. And at that level, at the continuation of the pharynx at the lower border of the cricoid cartilage, passes downwards in front of the vertebra through superior and posterior mediastinum of the thorax, pierces the diaphragm opposite the T10 vertebra and finally opens cardiac end of stomach at the level of T11. Now, this is the cardiac end. Now, at it level from T10, okay, pierces the diaphragm opposite the thoracic 10th vertebra and finally opens in the cardiac end of the stomach. Now you can see the constrictors and parts of the esophagus. Now the pharynx is here. The constrictors first, pharyngoesophageal junction. This is the pharynx and the esophageal begins here. The cervical portion 4 centimeters, esophagus, thoracic from here see 20 centimeters, and abdominal it is 1 to 2 centimeters. Now this is the diaphragm and you can see the cardiac end of the stomach. This is stomach and this is this Now the first pharyngeo-esophageal junction, second crossing of arch of the aorta, and third crossing of the left principal bronchus, and fourth passage through the diaphragm. Now, it might be a question of 5 marks. The constriction and parts of the esophagus described. So, you just simply draw and label. You will get your marks. Now, esophagus has the following curvatures. Anterior-posterior curvature first corresponds to the curvature of the cervical vertebra, whereas second corresponds to the curvature of the thoracic vertebra. Now, when I showed you, it is like this. This is cervical portion, this is the thoracic portion, and it continues. Okay. Now, and the lateral curvature side by side deviates 2 times toward the left. First at the root of the neck and second at the level of T7 vertebra. At the root of the neck when you dissect, also the thorax when you are studying, you see the root of the neck from there and again at the level of T7. At the level of T7. Now, constrictions. List constriction of esophagus and their levels. Question. List constriction and esophagus and their levels. Second narrowest part of the digestive tube, vermiform appendix is the narrowest. And you can see usually esophagus shows 4 constrictions, follows first constriction at the pharyngeo-esophageal junction, 6 inches from the incisor teeth. Now this is the incisor teeth, 6 centimeters from there is the first constriction. Okay. Now produced by the cricopharyngeus part of the inferior constrictor of the pharynx. Now, esophagus, second constriction at the crossing of arch of aorta, the 23 centimeters or 9 inches from the incisor teeth. 23 centimeters or 9 inches. First is 6 inches, then 9 inches, and third constriction at the left principal bronchus, 11 inches. 6, 9, 11 from incisor teeth. So, from the measurement from the incisor to teeth to, so 6, 9 and 11 inches from incisor teeth. Now the fourth constriction at the passage through the diaphragm, 40 centimeters, 15 inches from the incisor teeth. So, incisor teeth is the landmark, and from there the measurements and the constrictions appear as I told you. So, now relations of the esophagus has cervical, thoracic and abdominal parts. It's a simple thing that, see, the pharynx. Now from that is the cervical region, then the thoracic region, then it pierces the diaphragm and comes the abdominal part. Now, relations of the thoracic part of the esophagus, this is important. Everything is important, but this is a question, short note can be there. Relations of the thoracic part of the esophagus, anterior, the trachea, this is trachea, arch of the aorta, this is the arch of the aorta, right pulmonary artery, left principal bronchus, pericardium with left atrium and diaphragm. When you dissected the thorax, you will see all these structures. So you can now esophagus posterior relation. Now see this is the esophagus. This. Now this is a very good. Every book has a diagram like this, so you can draw posterior relations of the. You just. আমি যেটা বলতে চাইছি, you go on mugging, হ্যাঁ, মুখস্থ করতেই থাকলে, কিন্তু আমি what I want to stress, when you are studying anatomy, you try to draw these simplified diagrams and you label them. It will be in your server for more duration, and it will be easy to build up the story. Now you have answered 3 questions. Complete হয়ে গেছে। একটা এরকম জায়গায় you are now stuck. So you just try to figure out, remember what are the relations of the esophagus will be. It has to come from the pharynx and it goes down. Now the course traveled, you have to see relations, the posterior relation, the vertebra, cervical, thoracic, and in this way you build up the story and see what are the arteries. This is the descending thoracic aorta, the left posterior intercostal artery, this is azygos vein, sympathetic trunk, all are visible in the dissected bodies. And this is the esophagus, this is thoracic duct, cross to left at the T5 level. Now from the right side it crosses in the left at the level of T5, the thoracic duct. This is the heavy azygos vein, this is the azygos vein, now descending thoracic aorta, and this is the esophagus. Now this is a repetition, posterior relation of the esophagus. You can see it is very easy to draw these figures. You draw like this. And then you relate like that. Now esophagus, right lung and pleura to the right lung and pleura, azygos vein, right vagus nerve. To the left, the superior mediastinum, arch of the aorta, left subclavian artery, left recurrent laryngeal nerve, and thoracic duct, left lung and pleura, posterior mediastinum, descending aorta, and left lung and pleura. Now the histology has following layers. Mucosa consists of stratified. When I showed you in histology the stratified squamous epithelium, because malignancy is a squamous cell carcinoma is predominant in esophagus. So the submucous consists of dense irregular connective tissue with elastic fibers and compound tubuloalveolar gland. Muscularis externa, upper third esophagus has skeletal muscle fibers, in middle third and both skeletal and smooth muscle fibers, whereas the lower third only smooth muscle. Actually, the part that is from pharynx is skeletal and skeletal muscle fibers, and the upper third is esophagus has skeletal muscle fibers, in the middle third and both skeletal and smooth muscle, and whereas lower third only smooth muscle. Adventitia surrounded by connective tissue, only lowest 1 inch surrounded by serosa and peritoneum. Now, this portion, naturally stomach, which you've seen in the, I showed you, the cardiac end, it is now in the abdominal cavity. Naturally, portion of the esophagus that is there, it is covered by peritoneum or serosa. And this is the now clerical integration. Esophageal varices are dilated, tortuous submucosal veins in lower part of esophagus, cause portal hypertension. Pathology: increased portal venous pressure, cause shunting of blood from portal vein tributaries to systemic veins, vena cava. Lower part of esophagus, see portal vein, left gastric vein, and esophageal veins, site of anastomosis, azygos vein, superior vena cava. Symptoms: bleeding and vomiting in hematemesis. Now, you have to, like a person comes with a bleeding from the esophageal varices, then what happens? The blood percolates and goes into the stomach. Now, with the acid in the stomach, it transforms to coffee color. Now, you have to distinguish. বেশ তোমার সঙ্গে তোমার বমি হয়েছে, have you vomited? হ্যাঁ, কিরকম? একটু রক্ত তার সঙ্গে যেন মানে they cannot, most of the people are unaware of the color of coffee color. So you have to say কি খয়েরি রঙের হয়েছে? You have now difference hematemesis, blood vomiting, that is transformed into by the acid coffee ground color. But if he coughs, it's hemoptysis. Hematemesis from gastrointestinal bleeding, and from the lung, it is hemoptysis. It's frank red in color of blood. You have to, when you say, after kashi hai, when a patient comes with dyspnea and cold, high pyrexia, then you ask, when you cough, have blood comes out? He will say, yes, দুবার একবার বেরিয়েছে. Your difference is that the blood which during gastrointestinal bleeding is coffee ground, this is frank red blood. বলছে একটু আধটু বেরিয়েছে, কাশো, জোরে কাশলে তোমার বেরোয়. Now when you say that you cough, do you get red color sputum? বলো একটু একটু, মানে that's why there's one mindset is being there that আমার বুকের দোষ হয়েছে, মানে I have some tuberculosis. ও কিছু নয়. But you have to take care and see if it is a hemoptysis or hematemesis. Now, by your clinical knowledge and your anatomical knowledge, you have to distinguish, plus your clinical knowledge, you see that the patient is having bronchi, pneumonitis, and then you have to go for a chest X-ray, the PA view, to see if there is some infection or not. It might be like he's having a very bad pharyngitis. Hello, some streaks of blood. But frank blood from any pathological condition of the lung can be frank. So, but if there is severe bleeding in a hematemesis, then what happens? You have to give your out and out. You transfuse, you go for blood requisition, then you just have to give infusion and anticoagulant. Anticoagulant means the medicines that is required that stops bleeding, and send it for an emergency endoscopy. Then they will see that the varices is there in the esophageal varices. Now, there are different ways of handling this by endoscopy also. Nowadays, this is a great advantage. And you have to take a history of if he is having peptic ulcer or duodenal ulcer by his clinical history. Or there is some gastric ulcer, there can be hematemesis. And you have to take it that you do an endoscopy, but everywhere the endoscopy is not there. So your clinical knowledge has to act endoscope, say in every day it is not being done, conducted in centers. But you are in a medical college, it is expected by the time you go to the clinics, there will be a provision. But you have to keep in mind, even if you are not in the, you are passed out, you are an established doctor, you are serving some hospital or some clinic, then you have to keep in mind the hematemesis and hemoptysis. Hemoptysis actually frank cough, cups of blood, you can manage with this thing. But if it is in severity of hematemesis, then there are chances of death. And one thing is that if a patient comes with some pain and some like this, just it can be a mild degree, then you ask the patient that, have you passed stool, like black hair or the alcatra, that is black paint, or the asphalt, the road, এই কালো পিচের মতো হয়েছে, তোমার কালো চুলের মতো হয়েছে পায়খানা, then it is the gastrointestinal bleeding. It might be in small quantity. And in portal hypertension, ascites, cirrhotic livers, there we'll discuss when you are in the abdomen. So there is also esophageal variceal bleeding. So now this is the hematemesis, and also you will be reading thorax, that is lungs. So I have made it a difference between the what is component of hematemesis and the component of hemoptysis. I think you should not forget. You will remember till when you reach clinics and then pass out and become a doctor. You are already in the pipeline, you are already become half doctor, nahi bolega, quarter doctor in these 5 years. Anyway, you have to see, correlate, আর হাত তুলে দেবে না। When this type of emergency is there, you desperately do things that will at least then transport. Once you see this vomiters or something, you no, hospital niye jaan, hospital niye jaan. You at least give the necessary drugs and the IV infusion, and also there are plasma volume expanders like Hemaxil that is easily available in the chemist shop. You rush, flush kore dao, 500 ml DNS, then Ringer's lactate, you flush and then you give these drugs, that transuranic acid and these type of drugs which are modern drugs, and also antispasmodics, and transport referred to. Then the patient party feels that no, Dr. Barrett chesta kore amader line up kore pathiye diyeche. And when you are referring, if it is a hematemesis, you write GI endoscopy, emergency GI endoscopy, because the endoscope in modern gastroenterology, it is a very important tool and also helpful, and these things, severe bleeding conditions, pet kete selai korar jayga nei. The things don't permit the condition of the patient to, you stabilize the patient, you take a blood transfusion, and then slowly the skill you have to develop of the gastroenterologist who is there, he puts in the endoscope and then he manages. That stapling of these vessels. Now, histology of esophagus. Now, esophagus, mucosa, stratified squamous, epithelium non-keratinized, lamina propria, musculus mucosae, longitudinal smooth muscle. Submucosa, dense, irregular, connective tissue, elastic fibers, longitudinal folds, star-shaped lumen, and compound tubulo-alveolar gland. Musculus externa, upper third skeletal muscle, middle third skeletal and smooth muscle, lower third smooth muscle. Adventitia and serosa, connective tissue layer, 1 inch of esophagus has serosa. Now, the venous drainage of the esophagus, you can see internal jugular vein, this is the inferior thyroid, this is the subclavian vein, the right brachiocephalic vein, superior vena cava, azygos vein, and this is the diaphragm. This is the hemiazygos vein, accessory azygos vein, and here inferior vena cava, and you see short gastric veins in this portion, and left gastric vein, the splenic vein is here, and superior mesenteric vein. So as thorax, you will proceed to the abdomen, you will be seeing this is the continuation of the vascular system. Now, blood supply, lymphatic drainage, and nerve supply. Now, arterial supply, cervical part of esophagus supplied by inferior thyroid artery, thoracic part of esophagus supplied by esophageal branches of aorta, abdominal part of esophagus supplied by left gastric and left phrenic arteries, cervical part of esophagus supplied by inferior thyroid artery, thoracic part of the esophagus supplied by esophageal branches of aorta, abdominal part of esophagus supplied by left gastric and left phrenic arteries. Nerve supply, sympathetic fibers from T5 to T9 spinal segment are vasomotor and sensory. Parasympathetic fibers from recurrent laryngeal nerve and vagus nerves are motor and secretomotor glands. Now, referred clinical integration, referred pain of esophagus, heartburn, Esophageal pain carried by sympathetic fibers, T4, T5 segments. Referred pain of esophagus, heartburn. Esophageal pain carried by sympathetic fibers, T4, T5 segments. Esophagitis, inflammation of the esophagus, occurs in gastroesophageal reflux, GERD. Pain of esophagitis felt in the region of the chest wall supplied by T4 and T5 spinal nerves, lower thoracic and epigastric region. May be difficult to differentiate between esophageal pain from anginal pain. Now this is very important. See, a patient comes, না ডাক্তার বাবু আমার এই গ্যাস অম্বল হয় ওই আমি একটা ওই ওমেজ খাই ড্যান্ট্যাক খাই মানে when you are writing you might be writing esophagus, you might be writing anything. Patient says, না ডাক্তার বাবু আমি তো ওমেজ খাই. So these type of patient which comes with the symptom of gas ombol, means acidity and gas. In Bengali we are saying, ombol means acidity. Now, don't ignore. See, you tell him, no, you have to have a minimum an ECG done. So you get a ECG done, cardiac checkup, and if you see everything is okay, then you go. Definitely, these will be side by side. You are treating for esophagitis, you are treating for GERD, you are treating for your gastric reflux and hyperacidity. But keep in mind that you have to do cardiac checkup, but if you diagnose clinically that she's suffering from acidity and this thing, then too, you advise the Babu, you have to do this. See, one thing, if a patient comes with an appendicitis, you tell him you are having appendicitis. ডাক্তার কি করতে হবে? অপারেশন করতে হবে না? But if you tell him that you are having an anginal pain, of course angina has specific symptoms and signs. That quick you say, after a bathataki, it goes into the arm, in the left arm. If he says, do you have any difficulty in breathing after walking few steps? Do you having any dyspnea or pain over here? So you have to think in that term, that you think it that she is having a cardiac, maybe having a cardiac problem. So get it checked up and also advise him that you have to do this. But appendicitis is such a thing that heart amar kichu nahi, heart amar khub bahut acha hai, tagda hai, mera heart theek hai. But if you say the appendix, if the patient comes to me, I tell him, no, it's not appendicitis, you are having some colitis or some, you are having a bowel habit is not good, so get this, I am treating you for this. Appendicitis is there in his nut, and he will go within 2 hours, he will go to another surgeon. The surgeon says, "Hey, mone hocche eta appendix." He is not satisfied. He goes to a third surgeon. The surgeon sees, probably has seen it, and the third surgeon says, "Ektu mone hocche appendix ache." You come to know, you might not come to know if it's a big city, but that patient is being operated at 9 p.m. But appendicitis is not such an emergency that it will boom, blast to a More than 80% children with a right iliac fossa pain, if the appendix is located on the right side, if due to malrotation of the gut, which you will be studying in your embryology, it might be in the left side. cecum is on the left side, the appendix on the left side. It's due to some abnormality in the embryogenesis, organogenesis. But people, appendix se kaatte hobe. Don't do it. You be confirmed, and then only. Because recent report are saying that more than 80% that is diagnosed as an appendicitis was opened for surgery. It came out to be just inflammation. That can be treated with your simple medical treatment, medical management, medical word I love to say, a medical management of the surgical patient. तो इतना क्या हड़ी है, इतना क्या जल्दी है? Sokal, in the morning you get 10 a.m. you are seeing right iliac fossa tenderness, mimicking, I'm saying mimicking. Mone hocche jeno eta appendicitis. Get things done. Put him or her in antibiotics and fluid. Get an USG done, high resolution USG. Wait. It will subside, it will be okay. Especially children. Worms infestation is a very common problem. So don't, if you are a surgeon is a surgeon when he knows not to cut. A surgeon is a surgeon when he knows not to cut. Operation kore dilam. Hello, eta kore dilam. You will take your time, you will have your time, and nature will give you time. But you have to restrict. Don't try to make your ATM strong. I will just narrate a story. 30 years back, a girl, I think 9 years or 10 years, he came with acute pain in Sushobandha's clinic. Dr. Sushman Banerjee was a physician who got the Padmasri. Act Dr. Babu. Okay. I used to come that time. There was no, only few surgeons were there in Shian Hospital. They did not practice outside because the nursing home was not there, but Sushmanda's nursing home was built by my father, and then I continued, it got locked up. 86, I opened the lock. I saw that Sushmanda made it ready for operation, but when I came, he told me that whatever you think best, you do. I saw, and then I told him that no, you don't need an image. I don't feel that she needs a surgery now for appendix. I gave written some medicine and all, and then he got cured, followed up with Dr. Sushman Banerjee. Till date, now that one thing is that I used to go to Katiyar Medical College. In that time, I came at midnight, I dropped in return journey. I dropped in Bolpur station. Then one rickshawala, he saw me, Dr. Wu Pravadda. He was out with alcohol. Dr. Wu husband na, Amri Daran. He was recognizing me. Also, he doesn't want me to go to him because he's feeling a bit shy. I'm not here. Then suddenly one Maruti van came. Hey, Dada. He dropped some passengers, and then, hey, amader Dr. Wu ke niye jabi Bhuvandanga. So I took my luggage, went. Then the driver, he, Dr. Wu. I recollected that I seen his daughter. Then immediately I told him, asked him, I told, মেয়ে বড় হয়ে গেছে, ওই বিয়ে হয়ে গেছে, ছেলে মেয়ে হয়ে গেছে, কিন্তু অপারেশন করিয়েছিস? বলল না, অপারেশন করাইনি। If I feel every day I will operate on appendix, দুটো মিনিমাম সার্জারি করব, মাসে 15টা করব, আমি কম করে বললাম। But I have my hands tied up or I have put my hands in the thing. So a surgeon is a surgeon when he knows not to cut. This is a very important thing. If you feel that if I put yourself in the patient's party's side, on the opposite table. Now I have a granddaughter, she's 6 years old, 6 plus. If anything, there's a pain, I bring to one of you, my students is a surgeon, or my teacher. If he says, no, Dr. Yes sir, you have to operate, I will argue. Even if he's my teacher, I will argue. So be an argumentative. There's a book, How to Argue and Win Always. So you have to argue within yourself. নিজেকে প্রশ্ন করবে, always question. And one thing is, drastically, typhoid is a very common problem. In my routine blood examinations, I always order for a typhoid test. Among 90%, we might not have temperature or something like that, but typhoid is very rampant in our, I will speak of my area. I will speak of Bolpur, Shaithia and the district. Anyone who comes with a high pyrexia, think of not dengue, but think of typhoid. Then you go for these tests and get it done. Okay, now esophageal pain carried by sympathetic fibers, pain esophagitis. Now don't take for granted any pain in the chest, complaining of acidity or something, or not complaining. Or you say, no, you are having some cardiac problem, you have to rush to the hospital. Now, esophagoscopy, visualization of the interior of the esophagus using esophagoscope. Dysphagia, difficulty in swallowing may occur due to esophageal compression from external structures or narrowing strictures of esophageal lumen. Now, Achalasia Cardia, failure of relaxation of lower esophageal sphincter due to congenital absence of ganglion cells in the mesenteric plexus of esophageal wall, causes accumulation of food in esophagus. Radiological examination on barium swallow, radiograph shows bird's beak, rat tail appearance of the esophagus. Now, Achalasia Cardia. Now, that's a neurological problem. So, you order for a barium swallow, and also if your GI endoscopy, upper GI endoscopy, and you in the rat tail appearance of the esophagus or beak. Tracheoesophageal fistula, most common congenital anomaly of the esophagus. Abnormal congenital communication between trachea and the esophagus. Failure of development laryngotracheal septum. These are the conditions that will occur. A child when is born, then every time the breastfeed is being done, then they vomit. So, or at a distress, because trachea and this thing is connected. So you have to go and investigate. Now, carcinoma of the lower third of esophagus occurs mostly in the lower part of the esophagus, produces difficulty in swallowing. Barrett's esophagus. Now, lining epithelium of the esophagus changes from stratified squamous to simple columnar epithelium with goblet cells. Main cause of Barrett's esophagus is GERD, and pancreas precancerous condition. Now, this Barrett's esophagus can be a MCQ question or a short note. This is a descriptive. Yeah. Now, in clinics, esophageal varices, dilated tortuous veins and portal hypertension. Referred pain is esophagus, esophagoscopy, dysphagia, achalasia cardia and tracheoesophageal fistula.